Okay, so I'm going to be presenting a case with a gentleman who had a crush injury to the thorax and right arm. So let's start here. I don't have anything to disclose. So, so for the initial presentation, this was a 34-year-old man who presented, to the Ryder trauma resuscitation unit after being run over by a truck. On initial evaluation, his airway was intact. He had breath sounds bilaterally. He had obvious ecchymosis and swelling to his right shoulder and chest wall, with a big sort of hematoma present, basically like right around here. He did not have a right radial pulse, although he had 2+ pulses everywhere, although there was no evidence of pulsatile bleeding or expanding hematoma or thrill or other hard signs of vascular injury. He did not have any right arm function either, though he was able to move his other extremities. He presented with tachycardia to the 120s to 140s with a systolic blood pressure of 140. He was intubated due to some confusion and pain and for airway protection. His initial VBG is shown, notably his base excess was -4 with a hematocrit of 43 and a pH of 7.32. So, yeah, there's no other injury really noted on secondary survey, again, besides this area on his right shoulder and chest wall. So I guess starting with that, what would people want to do for initial presentation or initial workup? Would this be someone that you take to the operating room right away, or would you get imaging first, or how would you proceed?
Portland, Dr. Kasim, your comments, please.
Good morning. So I'm going to divide this case into pre-hospital and during transport and in-hospital care. So it is kind of important to attend to this patient in the pre-hospital. Sometimes you can extricate this patient pretty quickly and get the patient to the hospital rather quickly within minutes. And in that case, you don't want to waste too much time in the pre-hospital. But sometimes they are pinned down, they are crushed, and things are on top of them. So you have to know what to do in the pre-hospital setting as well, especially if you are thinking of crush injury as opposed to pinned injury. There's a vast difference from one to the other. So the patient was run over by a truck, and he has sustained injury to the right shoulder, right thorax. And I'm assuming that he was picked up very quickly and brought to the hospital, or the paramedics were smart enough to do pre-hospital care to the patient. What I tell my paramedics, we had a case like this a few years ago, and we went through the drill of teaching the paramedics, what they should be doing. And in particular, where Dr. Untrak works in Iraq, the military has trained the pre-medics, what they can do and what they should do in a setting like this, which is the management of the airway and methodical extrication of the patient and resuscitation with IV fluid, judicial use of IV fluid, and then looking out for all the nuances that you should be aware of, especially in crush injury. So now that you got the patient into the hospital, this patient is already intubated, and so you do a thorough physical examination and make a note of everything that you are observing. And prior to that, I think you should at least have the X-ray of the chest available, because he has sustained a chest injury. So what is the most appropriate fluid for this patient? And in this case, it is not blood, because There is no evidence of any obvious bleeding anywhere, unless you see a chest full of blood. It doesn't appear to be so because he is holding on to his pressure. He's slightly tachycardic, and it could be for various other reasons. And what is the right kind of fluid? It is debatable. Some people say it is normal saline, but the military says it is Ringer's lactate, believe it or not. And that's what they recommend that we use in cases like this, even though Ringer's lactase has 4 milliequivalent of potassium in it. And that is going to play a part in the resuscitation of this patient. So you give the patient appropriate fluid, and initially, I don't think you would be starting him on any antibiotic or anything like that. You would do a thorough examination and find out that there is a pulse deficit. So what should you do? And I think if it is available, you should send the patient to the CT angiogram to see if we can get a CT angiogram. Before that, I think you should give the patient adequate amount of fluid, so you have some urine. He's establishing some urine, and test the urine for myoglobin. At least record it in your chart that you have done that prior to other factors that come into play in the management of the patient. So I will stop there and let others have a go at it as well. Thank you.
Thank you, sir. Atlanta, Dr. Frisbee.
Well, I agree with that, but I think I probably would like to get a couple of other things. First, I'd like to know, this is a crush injury. Does he have any petechial hemorrhages in his retina or in his sclera?
No particular hemorrhages.
Okay. How about what did the fast show you? Pericardial fast.
Pericardial fast was negative. His abdominal fast didn't show any injury. And we did get an x-ray. I think I mentioned on the next slide actually, but his x-ray didn't show like a large hemoneumo or anything on that side, although it did show a scapular fracture and I think a couple of rib fractures.
I think one of the things, since he's holding on to his pressure and you've got lines in him, that I would probably take him down and get a CT angio, see where the roadmap looks, where it's broken. At that point, that'd be what I'd do next.
Okay.
Thank you, Dr. Frisbee. Let's go to Poughkeepsie.
Okay, I'm talking. I mean, his airway and breathing are covered through the intubation, and he has bilateral breath sound. So I would fluid resuscitate him. I would perform a quick rapid fast exam to see if he has any intra-abdominal injuries, and see, you could also notice some fluid within the thorax as well with an ultrasound. And then I would also get a bedside x-ray, which was taken. And if he maintains his pressures at that time, I'll take him to the CAT scan for a CT angio, and probably do a complete head-to-toe CT scan as well.
Thank you very much, sir. Sao Paulo, Dr. Calais. I'm sorry, did you have something else, Poughkeepsie?
No.
Okay, great. Dr. Calais, Sao Paulo?
Yes, I think this patient is in shock, maybe because the crash injury, but maybe in shock. He has a swelling on the right chest, maybe hematoma. When you see the elbow, you can see no pulse on the arm. You can remember the injuries that can have floating elbow. You can dislocation of the joints from the chest, and injuries of the artery and veins in this portions of the chest, arterial, axillary, and subclavian artery in this position, and sometimes maybe big hematomas and big swelling in this region, accompanied with the crash and other portions. So sometimes it's very important to know this. It's a very difficult diagnosis in this situation. I believe these patients need to go resuscitation. If have crush injuries, maybe irritation, these patients as well. And maybe sometimes may recover the patients with blood. patients in trauma sometimes need blood. And I believe this is very important. And you can find to find all the injuries because it's a very high energy machine. So I believe this can start with X-ray, FACS exam, but I think these patients need a whole body CT, angio whole body CT to find the injuries they may be not missing in this situation. That's it.
Thank you, Dr. Calais. Kabul, Dr. Tawari.
I'm fine with that one. Like, I think I'll go with the fast and the X-ray cross-matching and arrange blood. And at the same time, like, you know, they are saying that RL will be the best fluid, but still I'll go with NS.
Thank you very much, sir. Campinas, Dr. Fraga.
I agree. It's a high energy trauma. You need to follow the ATLS protocol. Now you have information about the FAST exam, information about the X-ray in the emergency department. And I agree, you need a CT angio, whole body angio to CT to investigate the injuries. And very important, the patient has a complete deficit on the right arm. I think this is important. Maybe he has only a neurologic injury, but maybe a complete vascular injury because no pulse on the right. So time is very important to definitive treatment for these patients. So the CT is, you need the CT to take the next decision.
Thank you very much, sir. Let's go, Dr. Post, Ryder.
Yeah, first, a quick disclosure. I do not know the case, even so Dr. Sumeet and I work at the same hospital, so I haven't seen this case before. I agree with what Dr. Collet said and Dr. Fraga. You know, the patient's in shock because he's tachycardic, and even so he hasn't dropped the blood pressure yet, you have to be concerned about it and maybe transfuse the patient. Number two is you always have to rule out life-threatening injuries in the torso first, right? So don't focus just at the extremity. Sometimes it happens, we see somebody has a major extremity injury and you put a tourniquet on and make sure they're not bleeding, but people forget about other injuries. You know, and as you said, this is a, you know, high impact case, so you have to be worried about intra-abdominal bleeding, injury to the thorax, and as the other speakers already mentioned, that all needs to be ruled out with fast and chest X-ray to make sure he's not bleeding into the cavity, maybe needs a chest tube on the right side, and you want to make sure he's not bleeding into the abdomen with the fast. Now, as Dr. Collet mentioned, if you have an expanding hematoma on the chest for an absence of pulse in that extremity, you're very concerned about axillary artery or subclavian artery injury. And if the patient becomes unstable, then you should go straight to the operating room and skip the CT scan. However, if the patient is hemodynamically stable and it's not expanding hematoma, then you could scan him and have a better understanding of the level of the injury and plan your surgical interventions. Thank you.
Thank you. Sarasota, Dr. Untrak, your comments, please.
Yeah, yes, my thoughts, I think, parallel Dr. Poos almost exactly. You know, it's life, limb, and then eyesight. So obviously, I need to rule out life-threatening injuries. The patient is already intubated, assuming he's being ventilated well, and you have the chest X-ray. So I don't think you need to spend time to put a chest tube on the right side here. And then based on the mechanism of injury, you know, you still have to be concerned about intracranial injury, cervical spine injury, and then the chest and the arm. The patient is severely tachycardic, so that's concerning. It looks like that would mean ordinarily that he would have lost at least 1/3 of his blood volume before he would even drop the blood pressure. But for a young man, a systolic blood pressure of 140, that's a little high. So I would expect that he would have a normal or low normal systolic blood pressure with the tachycardia if he were bleeding, and probably not to 140. So I'm a little puzzled about that. Suggests an autonomic cause, but not an intracranial cause. So in this case, I think, you know, I might look for myoglobin in the urine, and if it's there, I would start to alkalinize the urine, and then right to CT scan, because the injury is going to be probably in the region of the axillary artery, and it would be better to know exactly what you're dealing with rather than going straight to the operating room and having to explore and figure it out there. So I would in this case early on go to CT of the head, neck, chest, at least that, and I guess it's okay to do the abdomen, but based on the FAST and the rest of the exam, it's probably going to be okay. And then at the end of that, I would add in the angio CT to determine, rule out all the more life-threatening injuries, and then you can focus on saving the arm at that point.
Thank you, sir. Mexico, Dr. Perez Benitez, do you have a comment, sir? You're muted, sir.
I'm sorry.
Okay.
I do agree with everything that everybody said. I have just one question. What are the vital signs of the patient in the moment he's in the ER bay?
So at first his heart rate was kind of fluctuating between 120 to 140, with his systolic blood pressure kind of staying in the 130s to 140s. After intubation, his tachycardia had improved somewhat, although it was still kind of in the 110s to 120s pretty consistently when he was in recess.
Oh, okay. Then I agree that we should start resuscitation in this patient, and after this vital signs, I would also do the imaging test, the CT angiograms and the head CT without a stronger concern of the patient being hemodynamically unstable.
Thank you very much. Dr. Martos, Ryder?
Yeah, this was my case. So I like this case because there's a lot of things to think and a lot of alternatives to do. So I'm glad that Puss doesn't remember the case. I want to see his opinion and everybody's opinion on how to manage this patient. So Sumeet, please go ahead. There's a lot that is still to be present. Thank you.
Yeah, sure. So so basically, so I mentioned the chest X-ray, and I didn't comment on the FAST in the slide, but the FAST didn't show any fluid. The chest X-ray, there's clearly a right apical pulmonary contusion and a scapular fracture, and then on the CT scan, which I'll show some images of to follow, there was a short segment occlusion of the right subclavian artery with distal reconstitution of the subclavian and axillary artery. There was a right anterior chest wall hematoma that was quite large. It was 24 by 9 centimeters. He had a comminuted scapular fracture with, sorry, a typo there, it should be a sternoclavicular joint dislocation. So essentially he had scapulothoracic dislocation or dissociation from his chest. And then he also had some widening of the C1, C2 atlantoaxial joint, as well as the atlanto-occipital joint, some minor SP and TP fractures, a couple rib fractures, and also a right hemothorax that wasn't originally seen on chest X-ray. It wasn't massive, but it was clearly there. So this is an axial cut. So again, here is the chest wall hematoma. And then as you come further down, you can start to see this is where the subclavian and axillary artery or subclavian artery really should start. And there's no presence of it here. You can see it present proximally on this cut, and then distally here. So there's an obvious occlusion there. And this is on the coronals. You can see it pretty clearly. Again, this is the proximal end of the subclavian, and this is the distal end, kind of ending in the axillary artery. And here again, it terminates here and here. So this is your segment occlusion. This is the hemothorax that was seen on the right side. So again, not super large, but it does compress the lower lobe of the lung somewhat. And then this is a cut showing the clavicle, and how separated it is from the sternum. So the sternum really is around this area when you move the scan anteriorly. So this is the normal location of the clavicle on the left side, and then obviously a large dissociation on the right side. So pretty significant injury there. So again, I mean, from this stage, especially with regards to subclavian, I'm kind of curious what everyone's thought process is for management here. So I'll once again leave it to the group.
Campinas, Dr. Fraga, your comments, please.
Yes, first a question: how many hours until this moment, the trauma and after the CT?
Sure. So the trauma, I mean, he was picked up pretty much immediately after the trauma. So I would say it was, 10, 15 minutes from that. And then the CT scan, I want to say it was approximately 30 minutes after he showed up here. So in total, it's been less than an hour.
Oh, excellent. Less than 1 hour. In my hospital, just a case like this one, you'd call the vascular team to discuss with the vascular surgeons the possibility to treat this patient by endovascular with a stent at the subclavian. So I personally, I don't have experience with endovascular treatment, so you need to call the vascular team to discuss the case.
Mm-hmm. Thank you, Dr. Fraga. Let's go to Ryder. Dr. Poost.
And this is a classic Dr. Marta's case. He has enough. Like that. I agree with Dr. Fraga. So obviously, it seems like there is an injury to the subclavian artery right at the takeoff of the nominant on the right side. And it seems to be, there's probably not just thrombosis of that segment, because you have this massive hematoma. So it seems like that, you have a wall thickness injury, and it probably stopped bleeding once the hematoma reached a certain size and the pressure was big enough. So it stopped, because I didn't see any major active extravasation on the CT scan. Correct me if I'm wrong, Sumeet, if there was
No, there wasn't any major active extravasation that we saw.
So then, as Dr. Fraga mentioned, I think endovascular stenting is a good option here. If you do an open case, and you always have to be ready to do an open approach, right? If they can't do it, and obviously we would have to commit here for a sternotomy in order to get proximal control at the nominant artery at the takeoff. So you have to be ready and prep the chest and everything in case of, patient starts bleeding, becomes unstable, they can do it, to be able to do an open approach. But I agree with Dr. Fraga. It seems like it would be a nice case to consider to do endovascular stenting, and for that we would consult our vascular surgeons here at Ryder as well.
Thank you, Dr. Poost. Let's go to Mexico, Dr. Perez Benitez.
Yes, I will also talk to the vascular team. I do not have any experience with endovascular approach, so I would do that, and I would also call neurosurgery team or spine surgery team, and also the trauma and orthopedics team, which I presume would be the coastal and the fractures would be the last management and the less urgent to fix. But I would do that first. Do an endovascular treatment and neuro and orthopedics.
Thank you, sir. Poughkeepsie, your comments, please.
Hi, we agree with what's mentioned before. So we definitely don't have experience with open in management of these cases. We would definitely consult the vascular team. And I think even attempting open repair of this case would be very challenging because of the hematoma. So definitely an endovascular stenting would be the best option for this patient.
Thank you very much. Let's go to Sarasota, Dr. Untitled.
Yeah, so in this case, the most concerning injuries are the C1, C2, the C-spine injuries, and then the vascular occlusion of the subclavian on the right, and without causing further damage. So I think the neurosurgeons have to be consulted early on, and whatever you do, you want to try to avoid having to move the patient a lot or at all. And I assume that the neurosurgeons would say, okay, just keep the head immobile, and they may put I don't know if they put a halo or what they would do for it. But at this point, I think if the patient is not being moved and you just immobilize the head, you can proceed to do what you need to. And again, I also don't know if the endovascular people can pass a guide wire and a stent, or they may feel that it's too risky, that if they try to get the guide wire blindly to go through an area of complete occlusion, if they could open up an injury and cause bleeding, they may demur and not want to rock the boat. So I think in this case, I think that, and certainly what I would do when I was in my younger days and we didn't have endovascular surgery, in this case, we'd immobilize the head. And I think a possible solution through a small incision without having to enter the area of the hematoma, explore a hematoma, and potentially get into bleeding. You already have proximal control from the occlusion. And I would consider doing a small supraclavicular incision and a carotid subclavian bypass on the right side to revascularize the arm. And then fasciotomy would be a safe thing to do in the upper extremities with the advanced blessing of the neurosurgeons to be sure that they don't need to do anything first to prevent any injury to the C-spine.
Thank you, sir. Atlanta, Dr. Frisbee.
I agree with all the comments. This is a place for the endovascular guys first, at least to get their comment and see what they say. Also, it's certainly a place for the neurosurgeons. So I agree with what's been said before.
Thank you, sir.
That's all I got.
Okay, thank you, Dr. Frisbee. Sao Paulo, Dr. Collette, your comments, please.
Yes, I agree of all the comments. I think these patients maybe start with an endovascular approach and think about the fixation of the spine. But this approach is very important because when you have vascularization, the limb, you can this injuries to the artery is not only the artery. You have venous injuries, so you can increase the hematoma after you can have vascularization of the patient sometimes. So it's very important to do this, to know that sometimes the hematoma after you have vascularization, put a stent, the hematoma go increasing. And it's very difficult to control because in these kinds of injuries, you have association injuries of the veins, maybe not the proximal subclavian veins, but maybe tributary of the veins. In these veins is blending too much, more than artery. So it's very important to know that. So in this moment, I think these patients need to go angiography, study angiography, try to put a stent, must be careful because the revascularization may be problem. And I think I agree with the patients when they have vascularization, sometimes because the size of the hematoma, you need fasciotomy in this limb. That's the way I think.
Thank you, Dr. Calais. Let's go to Kabul. Dr. Tawari, your comments, please.
For me, like I don't have that much experience, but since he has some defect in C1 and C2, so I would really consider neurosurgery, and at the same time the vascular team, so that you'll get proper management. Thank you.
Thank you, sir. Portland, Dr. Kasim, your comments, please. Check your mic, sir.
I remember the patient has a first rib fracture. Anytime you see a first rib fracture, the amount of force that is needed to fracture the first rib is enormous. So be aware there are other serious injury in this patient that you're not really seeing. I think the first thing I would do would be to do no harm to the patient from his cervical injury. So I would call my neurosurgical colleague to see any further injury, make sure that I don't do any harm to this patient. Whatever he decides, he needs to do that first. I think this vascular injury is amenable to endovascular procedure, even though there is a total occlusion, and quite often it opens up, by having a guide wire and having, you can stent it quite easily. But the question is, does he have an associated venous injury as well? And that is going to be hard to tell on the angiogram. So I think I would get the neurosurgeon first and get his opinion and do an endovascular procedure on this through a femoral stick and go all the way up and put a guide wire and try hard to put a stent in. and then protect the stent with a small amount of anticoagulation to prevent any thrombosis. And then comes the chest wall lesion, and last comes the orthopedic surgeon to deal with the clavicular injury or claviculosternal injury. That is the algorithm that I would be following. Thank you.
Thank you, Dr. Kasim. Dr. Grisby, are you prepared to comment, or would you like to wait a couple?
I'd like to wait.
Okay, very good, sir. Go ahead and just give me an indication. I'll call on you. I think everyone's had an opportunity to speak, so in the interest of time, we'll just go right back to Dr. Jain.
Okay, so so what ended up happening, first we took him back to recess, and we ended up placing a right chest tube for the hemothorax out of concern that that could enlarge. And we also proceeded to get access, you know, again, in case anything happened requiring him to get blood and to monitor his pressures. Orthopedics and neurosurgery were consulted because of that, and also because of the cervical spine fracture, or not fracture, I should say. It was really more of like a, you know, widening concern for dislocation. And vascular surgery was consulted for the subclavian artery injury. So they did take him for stent placement. As I think was mentioned, intraoperatively, the chest was prepped and we were on standby in case, you know, they were unsuccessful or in case bleeding occurred during the course of their intervention and he required a sternotomy and, you know, open repair. However, they were successful in getting the stent across, and so he was admitted to the trauma ICU postoperatively. This is a CTA from about a week later to evaluate the stent, and so you can see the stent placed here. It actually does cover the right vertebral, but there's backflow to that on the rest of the CT scan. That's the proximal end of the stent, and then you can see that there's flow distal to it as well. So the stent was successful. He did get MRIs, which confirmed a brachial plexus injury as well as an unstable ligamentous C-spine injury. There was no actual surgical intervention for that. Neurosurgeons recommended a C-collar for 8 weeks and the brachial plexus injury to be followed up as an outpatient. As was alluded to, he did have a venous injury. It wasn't bleeding at the time, but he did develop a subclavian vein DVT from the crush injury that happened. And he was eventually started on anticoagulation when he was deemed safe, which was at least a week later. Interestingly, kind of the aspect that was not, you know, I would say not really focused on during the beginning of his treatment was that he began to develop worsening hypoxia and have pulmonary complications likely due to a fairly significant pulmonary contusion as well as the hemothorax that he had developed. So he had to be placed on BiPAP on post-trauma day 14. A CTA was obtained, which did not show any evidence of PE. However, it did show this this collection here in his posterior thorax, which extends down. So obviously, this is despite already having a chest tube in place on this side, which is lower, more basilar, I should say. So again, this is my kind of last round of polling the group. But what would you know, what would everyone do in that situation given these fluid collections in the chest?
Thank you. Sao Paulo, Dr. Calais, your comments, please.
Okay, in this situation, I go to the patients with clots in the lung and the pleural cavity. I go to patient to OR to pick thoracoscopy, evacuation of the chest, the clots, and put a chest tube under vision. That's the way I go in this situation.
Thank you, Dr. Calais. Kabul, Dr. Tawari, your comments, please. Go ahead, sir.
I think I'll just, you know, honestly, I don't have anything to share now.
Okay, very good.
Because I say like it's like 2 weeks. It might be like you know, infectious cause or something like.
Okay, very good, sir. Thank you very much. Portland, Dr. Kasim.
Well, before I take the patient for a VAT, I think I would try another chest tube to see if I can at least see what is collecting there it's more than a few days old, so I may not be able to drain it. And if I can, then of course I would follow what Dr. Coley has suggested, thoracoscopic drainage, evacuation, lavage, and putting in adequate chest tube to drain that part of the area where he had collected before, to make sure there is no reaccumulation of any further blood and fluid collection after I have drained it. Regarding the subclavian vein injury and thrombus in that, I think, like I said, I would have started him on anticoagulation a little bit earlier, anticipating that he may have that, and thereby I may have prevented the thrombus in the subclavian vein. But I think it is acceptable to wait sometimes when you are in a situation like this. Thank you.
Thank you, sir. Ryder, Dr. Poost, your comments, please.
Yeah, I'm a little bit concerned about putting him on BiPAP if he is hypoxic and is going on acute respiratory failure. I tend to rather probably intubate the patient than doing BiPAP on somebody who is deteriorating. And I agree with Dr. Collet. I think I would also do VATS on him. Another option to consider is TPA lysis through the chest tube. But I'm a little bit concerned that, as mentioned before, maybe he had a subclavian vein injury, maybe there's connection to the pleural cavity and stuff. So I'm not so sure if I would do TPA lysis on this patient. I would just rather do VATS in the OR. And regarding the early anticoagulation, yeah, it may prevent the DVT in the subclavian vein. Also, if it was injured or crashed, you're probably going to end up with the thrombus no matter what. The other concern is I don't know if neurosurgery would clear you so early to put him on full anticoagulation with this high C-spine injury. There's obviously also a concern of bleeding into the spinal canal. So I don't know. I'm not sure if you would have been able to prevent it necessarily in the subclavian vein in this specific case. But I would do a VATS as well.
Thank you, Dr. Poost. Atlanta, Dr. Frisbee, your comments, sir.
Well, it's been 14 days. If you think you're going to suck that out, I don't think you are. I don't have very much experience with the VATS, and in my hands, it probably wouldn't do me any good. I probably would just decorticate the lung with my hand. After 14 days, it's going to be fairly organized, and I think I would go ahead and put the chest tube back in there after I pulled out all that organized clot. See if it reaccumulates. But other than that, sounds good. Thank you.
Thank you, Dr. Frisbee. Campaigners, Dr. Fraga.
Just one question first. The patient at this moment was on anticoagulation?
Yes, it had been started by that point, yeah.
Okay. I think that is a good solution for this case. To clean the pleural cavity. So thoracoscopy is the option here.
Thank you, Dr. Fraga. Mexico, Dr. Perez Benitez, your comments, please.
I would also do VATS and replace the chest tube.
Thank you, sir. Sarasota, Dr. Untract, your comments, sir?
Yes, I'd be concerned why the first chest tube had been in for this long, and I assume it was probably draining, but not draining enough to keep that other collection from forming. Also, it looks multilocular on the CT scan, so I think it's reasonable to try to put a second chest tube to drain it, see what effect that has. And if it's, assuming that if it's multilocular, you can't drain it completely or further problems, then the VATS is obviously the next step. And as Dr. Frisbee said, because it's 2 weeks later and ongoing problems, he may eventually come to a decortication. But to start, I would start with the smallest, the chest tube, then VATS, and then see how he does after that.
Thank you, Dr. Untract. Poughkeepsie, your comments, folks.
Go ahead.
being that this accumulation is 2 weeks later, you are worrying about infection and the patient is symptomatic because he's hypoxic. We're starting him on BiPAP. So I think putting a chest tube would probably buy you a day or two of trying to figure out the ultimate management, which still would be a VAT. So I would probably start right out with the VATs rather than a chest tube. As far as the anticoagulation, I guess my questions are, one, for the stent, whether we considered aspirin early on, and was DVT prophylaxis started immediately, like post-op day 1 or 2, once the patient was stable? That's a question.
So to answer that question, DVT prophylaxis was started early. Relatively speaking, I think we had to wait a couple days because on the MRI there was a concern for like a small epidural from the ligamentous injury of the spine, but it was started within the first few days post-op. And then as far as aspirin, that was actually the recommendation as far as the stent was concerned from vascular, because it is a fairly proximal stent in a large size vessel, so there wasn't a need for full anticoagulation as far as the stent. However, because of the subclavian DVT, that was the reason that full anticoagulation had been started.
Does that answer your question in Poughkeepsie? Okay, thank you very much. Not sure if Dr. Grigsby is prepared to comment at this time. Give him an opportunity to comment.
Yeah, I think you're going to wind up having to do a VATS just to get that out. I don't think it's coming out with the chest tube.
Every week he has this big boardroom trying to get all his residents to go in there.
And no.
I'm sorry. Okay. Thank you very much. So everyone's had an opportunity to comment. We'll return to Dr. Jain.
Okay. So so the patient did undergo a VATS. I think that CT scan was done about, again, it was done out of concern for PE at the time, since we knew he had a subclavian vein thrombosis, and then we found that collection. So he underwent a VATS with a partial decortication and washout. Over the course of his hospitalization, I mean, it was complicated by numerous pneumonias with ARDS, which required him to be put on APRV and proned and paralyzed and all these things. But he eventually recovered from that. On post-trauma day 30, he actually developed an upper GI bleed while in anticoagulation, where a gastric ulcer was found, and this was controlled with endoscopy, hemostatic clips, and cautery. And so at this point, an IVC filter was placed, especially when the patient was found to have a femoral DVT. By post-trauma day 35, he was finally sort of stabilized enough from his respiratory issues and everything else that had happened that he underwent the orthopedic procedure to relocate his sternoclavicular joint and plate it. Almost 2 months later, he was finally on low enough ventilator settings that we could do an open tracheostomy. And then basically by post-trauma day 72, he was out of the ICU. And by post-trauma day 81, he was discharged to rehab. So obviously, I guess I sort of forgot to mention, but shortly after he was put on BiPAP and got those scans and he went to the ICU, he was intubated before the procedure, and then he remained intubated essentially until he was trached, and then eventually, almost 3 months later, he was discharged to rehab. Since that time period, he has been seen in trauma clinic approximately 3 months post-injury and about a month after his discharge from the hospital. He did have atrophy to his right arm. He could shrug his shoulders, but he had no other right arm motor function and no sensory function to the right arm, although all of his respiratory issues had essentially resolved by this point. So he does a follow-up with orthopedics and neurosurgery and will likely need further procedures with regards to that, although that is still kind of to be determined exactly what the plan is going to be from that standpoint. But, again, he at least made it out of the hospital so far. So just a couple of quick things I wanted to talk about. The two major points I think in this case, number one was the subclavian artery injury, and the second was the retained hemothorax, especially since it was delayed. I mean, again, it was like 14 days later. So as far as subclavian artery injuries go, the most common operation that's performed for it really is an open operation, but I think a lot of that is due to the nature of the injury when it presents. So in a lot of cases of penetrating injuries and things like that, there's usually large circumferential laceration or transections with shock, and so obviously in that case you're going to go for an open injury, open repair. Most of the endovascular cases were done for pseudoaneurysm, and that was in about 17% of the cases that were done. But again, in this case, we had a complete occlusion essentially without any, at least at that time, active bleeding from the subclavian. So I think the patient was in a condition where he could, and obviously it worked, but where he could receive the stent. Limb salvage rates for subclavian artery injuries are very, very high, though, 97% in both cases. So, so that's, obviously a positive. There have been numerous case reports about subclavian artery stenting for blunt and penetrating mechanisms. So I think the bottom line is a lot of it really depends on the patient's condition at the time. So if subclavian artery injury is found and the patient's not in profound shock and has time to get a CT angio to determine the location and can go for endovascular placement or stent placement, then that might be the best option compared to doing a sternotomy. But again, if the patient's in shock and is bleeding out, then obviously that's not really an option. And then as far as VATS for hemothorax, so retained hemothorax obviously increases the risk for complications, and this is what happened in this case. So prolonged hospitalization, prolonged ICU length of stay and ventilator days. A large portion of them will get a pneumonia or an empyema, and if this is not treated early, then it can eventually lead to fibrothorax with trapped lung, which can obviously cause major problems. Historic rates may be even higher than some of the more recent studies as far as these complications. There is some evidence that maybe thoracic irrigation during initial chest tube placement with a couple liters of fluid can decrease the need for secondary interventions. However, I could only really find one study that talked about this, and there hasn't really seemed to be any follow-up yet, so that'll have to be investigated. Fibrinolytic therapy was mentioned, and that can be considered in patients who are poor surgical candidates especially, but just keep in mind that it can have a greater than 30% failure rate in this particular situation, as opposed to patients who have an isolated perineumotic effusion or empyema that's being treated, where it is usually more successful. And VATS is definitely, especially in these types of multiloculated retained hemothorax types of situations, VATS is the preferred surgical approach. Even after 7 days, it can be attempted, although the rate of conversion to thoracotomy obviously is higher, as the lung is usually much more adherent to the chest wall, and it can be harder to find your way inside the chest cavity with a camera. So, so that's it.
Thank you, Dr. Jain. Let's go to Campinas. Dr. Fraga, for your final comments, please.
Excellent, very difficult the case, and congratulations for the good treatment. Excellent case.
Thank you.
Thank you, Dr. Fraga. Dr. Frisbee in Atlanta, your final comment, sir.
Very good case, very thought-provoking. It brings up things I haven't done in a long time. Very well done. Thank you.
Thank you, Dr. Frisbee. Sarasota, Dr. Untrack, your final comment, sir?
Yes, nicely done. So I think the neurologic deficit is expected with a crushed but anatomically intact brachial plexus. And I imagine the neurosurgeon said that he can probably expect to get reasonable recovery of sensory and motor function in about 4 to 6 months. So I think there's still some hope for optimism. And then after the episode of bleeding from the ulcer, did you continue the you put the IVC filter? Did you continue or stop the anticoagulation?
We stopped the anticoagulation at that point, and I think just started aspirin for the stent.
Mm-hmm. And no edema of the arm, and he's got good collateral flow.
Yeah, so I guess I kind of glossed over that, but he did have, I mean, he had a little bit of edema, but he never had anything approaching compartment syndrome. His CPKs were initially elevated, but they weren't, I mean, he didn't have like urine myoglobin levels that were detectable or anything like that. So he never really developed rhabdomyolysis, which I was kind of surprised at given the extent of the crash injury. But yeah, from that standpoint, he actually didn't have any issues really.
And lastly, what about the clavicular or sternal separation? Did that need anything done for that?
Yeah, that had to be plated. So that was about a little over a month later, when he was finally sort of well enough from his ICU issues and everything, he was able to get that plated in place. Mm-hmm.
Thank you. Well done.
Thank you, Dr. Untrack. Portland, Dr. Kasim, your final comments, please.
Very nice. I like it. I like the way you approached it. I like your thought process and your the way you organize how to go about. But it's sad that he has brachial injury, and that may not come back because, in my experience, usually it doesn't. I had a patient like this who eventually went to Austria. There's a gentleman in Austria who repairs brachial injuries and apparently has the world's greatest experience. And he got some of his use back, but it took a long time. Very nicely done. I learned a lot the way you organized it today. Thank you.
Thank you, Dr. Jain. Poughkeepsie, your final comments, please.
It was a very good case. Tough case to handle, and congrats on getting the patient out of the hospital safely. There are some questions here about the timing of the tracheostomy. Day 58, I know it was, he was extubated for several days and then had to go back on BiPAP and then was re-intubated, but we were wondering why it took so long to get a trach into him. And then the other question. Sorry, go ahead.
Yeah, so the reason was, so he had been extubated previously, but then he was re-intubated around the time of the VATS, and he developed really bad pneumonia and ARDS. So his ARDS was severe enough that, with proning and paralysis and high PEEP or an APRV and things like that, he just did not have safe enough settings to be able to do a tracheostomy until, that day 58 at that point. So.
Gotcha. Yeah, we figured this is such a complex case that there has to be other issues that were standing in the way of what you needed to do. But congrats, good case.
Thank you very much for your comments, Poughkeepsie. Sao Paulo, Dr. Calais, your final comments, sir.
Congratulations for the presentation of the case. It's a very important case because you can see association of the injuries of the subclavian, artery and vein, and brachial plexus in this patient. It's sometimes very difficult to treat all them. And when I have these injuries on the brachial branch, you have a extraction of the branch, of the nerves. It's very difficult in these situations to recover this nerve. It's different even to have a section by a bullet or by a knife. There is more prognosis when you have these injuries. But it's very nice case. It's very difficult to treat this patient. Congratulations to share with us your case. Thank you very much.
Thank you, Dr. Calais. Norfolk, Dr. Grigsby, your final comments, please.
Yeah, can you guys hear me?
Yes, sir, loud and clear.
Yeah, so, this is a great case. Caught the tail end of it. Congratulate you guys on a patient well cared for, and thank you for sharing.
Thank you, Dr. Grigsby. Mexico, Dr. Perez Benitez, your comments, please.
It was a really, really nice case. Congratulations, and thank you for presenting this very challenging case. And hopefully, the patient will have a near full recovery. Thank you very much.
Thank you, sir. Kabul, Dr. Tawari.
Great case. I learned a lot. Congratulations. Job well done. Thank you.
Thank you for your comments, sir. Dr. Poost, Ryder, your comments, please.
Great case, Sumeet. Congratulations. I think it's a classic example why trauma surgery and critical care is one specialty and one fellowship, because you need your surgical skills to save the patient at the beginning, and then you require your critical care skills to get him through the severe ARDS with proning and advanced ventilator modes. You could easily have lost him from the ARDS down the road, and you were able to save him in the ICU subsequently. So I think it's a great example why it's so important to have good understanding of trauma surgery, but also of critical care physiology combined. The other thing is the data you showed from the Western Trauma Association. I think for blunt subclavian injury, endovascular approach is more frequent, more common. Our colleagues from vascular surgery get very good in dealing with those kind of injuries and getting the wire across. Sometimes they also come combined from distal and proximal, so they may cannulate through the radial artery and bring a wire up retrograde. Often they're also able to control bleeding by putting balloons on each side of the injury, inflating endovascular balloons to control bleeding. So they got very good technically in dealing with this kind of injuries. As you mentioned, with the penetrating trauma, it's more often that you deal with active bleeding to the outside or into the chest cavity, and you're not going to have the time to do that. And for those, you need to do an open approach. But obviously, the morbidity of an open approach to a subclavian artery injury is significant with opening the chest and everything. So great case, well done, well thought through, and congratulations.
So thank you very much, Dr. Poost. I'm gonna turn it over to Dr. Martos in a moment for the final closing comment. Before I do that, does anyone else have any other comments or questions?
I just want to thank everybody for their comments and for a great discussion on this case. So thank you again for joining.
Thank you for presenting, sir. So Dr. Martos?
Yes, so another good case. When the fellows come to Miami, you're gonna to interview for the fellowship. I say you're gonna end the fellowship fearless about critical care patients, and you're gonna see cases here that are tough to see. There's a kind of case I like, this kind of case where you need to think about the management, see the best next steps, and Sumeet, you did a great job managing this patient. Congratulations. And your presentation didn't reflect at all how complex this patient was, how sick he was for a couple of weeks. You did a great presentation, but the stress, the pressure to manage this patient was way higher than in the presentation. Congratulations. Let's please, again, this meeting has been great. Every week we have more people participating. Remember, every first week of the month, you're going to have a meeting at Wednesday at 6 p.m. Miami time, where we're going to have a case presented mostly in Spanish and English to the Panamerican Trauma Society. And I really stimulate you all to schedule to present a case in the next few months. It's nice to have your service presenting a case, showing how you manage some sick patients, have all these people, these professors in this forum discussing the management. Thank you very much.
Hey, Tony.
Yes.
Don't you know that Dr. Jain is following the rules? You never let him see you sweat.
Yeah, sir. If you guys have the opportunity, join the Panamerican Trauma Society. It's a nice society. We are looking for the presidential meeting in person this year still, if possible. And any doubts about how to get a member, become a member of the society, let's talk to Dr. Poost. He's in charge of the membership committee. Okay. Thank you all. I'm gonna finalize this and let Dr. Poost talk a little bit, and then I'm gonna finish the meeting. Thank you.
Yeah. One thing before Dr. Poost, next week, I believe, is Dr. Calais presenting. Is that right, Dr. Calais?
Yes, I am going to present next week.
Okay. So from what I understand from all the doctors, whenever he presents, you don't want to miss it. That's all I have, Dr. Poost.
Yeah, just very quickly, maybe, since we have a lot of people from different sites who are active in the Pan-American, we're trying to revamp our approach to bring new members into the Pan-American Trauma Society, young people, students, residents, and fellows, and so on. And also the members who have been members for a long time but may have been lapsing their membership fees, to try to bring them back and become more active. And the hope is that we basically at the major centers that we have identify what we want to call as an ambassador for the Pan-American Trauma Society at each center, who will focus on the efforts at each hospital to recruit young members, and also to make sure that the members who are already part of the Pan-American Trauma Society pay their annual membership fees and become more active in the monthly and weekly conferences. That's all. Thank you so much.
Thank you, folks. Thank you all for joining. Please take good care of yourselves. Have a good week and a good weekend. I look forward to seeing you next week.